Okay, so I've made a bit of a slideshow comparing two patients. So both were long-term rehab patients. One I had in fourth year, one I had in fifth year. Even though it was only a year apart, I think that the things I learnt from that patient in fourth year really influenced how I went forward in fifth year and was better able to manage um, rehab and patient management in fifth year. They both had really good outcomes regardless, but it was, I think, a really important learning curve for me personally in how I treated and how I planned my treatments as well. So the fourth year case is going to be appearing on the left hand side and the fifth year case will appear on the right. So my fourth year patient presented to me in probably my second week of clinic. He had just come out of a moon boot. He'd ruptured his Achilles playing soccer. He was quite young. He was only 19 at the time and had gone down the surgery route. He is from the country, so he'd had all his doctors and physios in his hometown managing him up until that point, and then he'd moved to Melbourne to go back to uni. So he came to me mainly presenting with right-sided lower back pain and some right hip pain because of walking with the moon boot and crutches for those few months after the surgery. His left calf was probably about half the size of his right, so he had a significant amount of atrophy. He also had a lot of scar tissue around where they'd made the incision, and he had a significant loss of range of motion in that ankle as well, particularly dorsiflexion. He was still very, very hesitant on weight bearing on that left side, even though he was out of the moon boot and had been given the all clear. So in terms of that first treatment, my working diagnosis was non-specific mechanical lower back pain due to altered gait post Achilles tendon repair surgery. So I did look at that Achilles and the ankle, but we did focus mainly on that main presentation, some symptomatic treatment, just to get him on track. He was quite happy for me to then look after him going forward in his rehab for the next few months, which was great. So in comparison, in fifth year, I had a patient at the clinic at the Western Spurs. So she had a 3-year history of multiple subluxations to her left shoulder, including a few complete dislocations as well. So that's all from playing footy. Her shoulder was always painful, dull ache at rest, sharp on movement. Always felt very unstable to her. She's got quite a physical job lifting boxes in a warehouse, so that was a bit of an issue for her. It could get flared up quite regularly just from work, but then obviously coming into the football season, both work and football made it a lot harder to manage. She did tape her shoulder for games and had it looked at previously, mainly by the osteos in the previous season, but hadn't had any huge changes to the shoulder itself. She had imaging done when the first dislocation happened, but because it was so unstable, she said that usually if she feels like it's dislocated, she can sort of put it back in herself, which, is a bit concerning, but she was pretty happy with being able to do that. It was more the management so that she could keep playing footy. She didn't want to miss too many games this year. So on testing, there was definitely an increase in the APPA shear of the GH, positive Hawkins-Kennedy, positive apprehension, positive open and empty can, positive O'Brien's, terrible muscular control for the upper limb screen. It was painful and a lot of crepitus in abduction, flexion, most movements really, but there was a little bit of a decrease mainly in that abduction and flexion, just not being able to get it to that full range. Nothing too crazy though. The grinding and clunking said that was something that maybe worried her a little bit, mainly because it sounds painful, not necessarily that it caused a lot of pain. So my working diagnosis for her was chronic left rotator cuff tendinopathy and shoulder instability with a suspected labral tear from history of multiple dislocations and subluxations. Already between the two, going into my assessment was massively different in 5th year. I really wanted to have a good idea of where the shoulder was, so I did a lot of testing in that first treatment to make sure I had some benchmarks to sort of see whether any of those things changed. We did those ortho tests every treatment for the first few, and then every few treatments after that, as opposed to 4th year where it sort of didn't occur to me that I should have something to use as a benchmark, so that I could really measure the progress and keep track of it and be able to progress the rehab accordingly to whatever benchmark I was using. So already that was something that I'd noticed that had changed a lot over that year. So my 4th year patient, he really wanted to get back to playing soccer by September. So that was about 6 months from that first consultation. And my goals as his osteo was to restore range of motion and strength. Quite a basic treatment plan, obviously. I'm not sure if it was completely realistic to get back by September, but I told him I would give it my best shot in helping him get to that. Whereas my focus was mainly to get everything moving and stronger again so that there wasn't going to be any issues in the future. 5th year, already a lot more detailed, so it was specific to the patient's goals, so getting through the season with minimal re-injuries to the shoulder. My treatment plan was broken down. I sort of had decided that and discussed that with her from that first treatment. So weekly treatment for the first 6 to 8 weeks, and then reevaluate the rehab plan weekly during those 6 to 8 weeks. If there was anything in that time that sort of suggested that we weren't getting any changes, then we were going to go off and get additional scans just to make sure that there was nothing sinister going on, or there was something that I was missing, which obviously would change how it was managed and how it was going to keep progressing. Rehab-wise, I wanted to focus on range of motion to start off with, but then getting that stability back. So it was a lot of tendon rehab protocol, so our isometrics, concentrics, eccentrics, as well as just general muscle control around those shoulder muscles from about that 8 weeks onwards. So massive difference. It was something that I had decided to focus on in 5th year, being that my treatment plans and knowing where I was going with the patient wasn't something I had sort of thought about too much in 4th year, so it was really good to have that mapped out and to be able to tell her that's how that was going to go. She obviously was able to book in weekly if there was injuries throughout the season, but we did follow that almost perfectly. So about 6 weeks in, we were able to start going to fortnightly because there wasn't anything that was super concerning and the symptoms were starting to get a lot better managed. So it was really good to have that change in management for me, and it's something that I can now implement with all my patients so that they have an idea of how often they're going to be coming in as well. I think that's really something that's very important to them. So 4th year, going into our evidence-based practice, I found a few protocols for tendon repair, surgery, rehab, so that I could base my rehab off those. So there's a link to 2 of those there. I'll go through those on a separate recording. I think that I was a little bit ignorant in my thinking that I could alter those to better suit myself, probably more so than the actual patient, and I didn't follow those perfectly, and in hindsight I think it would have been beneficial too, just so that we had those measures. So the protocols always offer those steps that you need to be able to achieve before you move on with rehab. Whereas I think I got a little bit excited when we saw improvements and I was progressing things either too quickly or not in a way that was going to give really good results. So I didn't have those things that I was looking for before we moved on from rehab, and I didn't have things that I was measuring to say that it was definitely improving, which I came into fifth year knowing that I was not as happy with how that had gone, and was something that I was definitely going to be doing better in fifth year. So fifth year I used Physitrack for the programming. It's not necessarily based off any protocols or anything, but the physios that create the programs use the best evidence available to create them. I did still alter them slightly, either adding like 1 or 2 exercises per week or per fortnight that were a little bit more football specific. So being a defence player, she was doing a lot of grabbing and dragging down. So that lat activation and control was really important. So I was definitely tweaking it, but I didn't change it as much, I guess, as in fourth year. Having that structure already there made it a lot easier, and having something that was easy to measure, so you can track the adherence, pain levels, you can get feedback from the patient. It's all through an app. They find it really easy to use. It was just so handy, and having that all available was just fantastic to be able to see, and you could go, yes, we're definitely making progress, or there was weeks where pain levels were going up, so what had we changed, and what were those things that were causing the pain, and how could we alter them to get that back under control. I have a link to that on the next slide, so we'll go through the full program in another recording again. So I think that was really interesting. Physitrack's a great program that we can utilise for patient management, and they really enjoy using it as well, from what I can gather, and I have been getting really good compliance with using it as well. In terms of my outcomes for both of these patients, like I said, they were both positive. So in fourth year, the patient was very compliant. He was very motivated. Like he really wanted to get back in that 6 months mark. So any time that we had a discussion about making sure he wasn't overdoing it, or every time we changed rehab, very compliant, exercises done daily, all those extra things that we were sort of discussing, like looking after his diet, or getting his cardio fitness back up using things that weren't as much impact, like a bike, for instance. He was really good with all of those. Fixing his gait was one of the most mind-blowing experiences, because I didn't give him any specific rehab for it. I just mentioned to him on the tail end of a treatment that the next week I wanted to focus a little bit more on how he was walking, and mentioned about how his foot was slapping as he was taking a step. He just lost that control of sort of controlled dorsal to plantar flexion and toeing off as well. So I'd only mentioned that to him in sort of passing, and then the next week he came back and he was walking perfectly normal again. So he was very body aware, very good at picking up on when I'd said things that weren't quite right, and then concentrating on those and coming back to me the next week. It did make it sometimes quite difficult to manage his rehab programming, because he'd come back and he'd sort of be a bound ahead of where I'd sort of planned up to. But that's where I think it should have still been more controlled, and I should have still given him those limitations, like, no, we're not going to progress, even though you've gotten much better over the last week or 2 weeks since I've seen you. We're still going to keep with those exercises and just get them 100% spot on before we move on to the next one. So there was a little bit of jumping ahead at times just because he was doing really well with those sort of things. In terms of 5th year, we had our regular weekly treatments for that first part of the season. And then sort of at about the 8-week mark, all of the ortho tests that we'd started with being positive came back negative, which was a really huge positive outcome, really great motivator for both me and for her to be like, this has really made a positive change. Again, very compliant patient, which just really helps with these sort of things. Each time that there'd been a setback with a knock from footy and that impact on work, I think it kept her really on track to be like, it doesn't have to be like this all the time. So we kept track of the pain levels on PhysiTrack. I would sort of have a look at those. I could check out her compliance as well. She was doing all her exercises daily, but that massive change in the symptoms, so a lot less pain, full range of motion, and all those negative ortho tests were really great outcomes and kept us on track for the rest of the season. So I've sort of gone over a few things as we've gone through the slideshow, but in reflection, there's some things that I did really well. My ability to motivate the patient, keeping it specific to what they were wanting to achieve really helps keep the rehab compliance up, as well as it helps to create the rehab. So being like, this is why you need these exercises, because they're going to help you with X, Y, and Z in your sport or what you're trying to achieve, was something that I did well with both patients, and I think helped with, they were already going to be compliant, I think, anyway, but it helped keep them motivated and kept them coming back to me as their practitioner to keep getting their rehab, and they sort of didn't lose hope that they weren't going to get to where they wanted to be, which was really cool. My patient management improved just so dramatically from 4th year to 5th year. Walking away from 4th year, even though I'd had that positive outcome and I knew he was really happy, he was very grateful that he got back to soccer when he wanted, I walked away feeling like I could have done a lot better, and I really wanted to make sure if I had that sort of circumstance come up again in 5th year that I was going to be better prepared for it. And even going into just normal patient treatments, getting better at my management, and knowing how often I was going to be treating them, really like having a treatment plan in place that matched their prognosis, was something that I wanted to focus on in 5th year, and it is something that I've improved on this year a lot, and I'm very happy with how I'm progressing. It still needs work, but that's going to come with experience, as I see more and more patients with similar complaints and have a better idea of how those treatments should look. Things I did not so well, I kind of already mentioned this earlier, so skipping bits and pieces or jumping ahead with rehab, getting a little bit too excited and progressing things when they shouldn't have been progressed, especially in 4th year. Not so much in 5th year, thank goodness. My treatment and planning and the prognosis in 4th year, like I said, I've sort of just mentioned that anyway, so it's something that I'm still improving on, but that it has improved so much in the last 12 months. And some things that I took away from it was having things to use as a measure. My use of outcome measures probably wasn't ideal. I didn't use outcome measures for either patient, and it's something that I struggle implementing into my clinic practice anyway, and something that I will need to keep working on. They definitely can be helpful. I just find them really hard to use, I guess, or implement. But that's another sort of learning objective of mine for the next few weeks. Another thing that I really learnt was being careful with how much encouragement you're giving them to move without overdoing it. But encouraging movement in a sort of that manageable pain threshold, and getting them to keep track of things that are causing that flare up, or making them a little bit more body aware to be able to tell you those things that are causing issues, was really interesting. And once you sort of got them paying attention to their bodies, the things that they came back or achieved were really interesting and incredible. So that probably comes into the educating patients as well. So that last point, getting them to understand why you're doing what you're doing really helps, and why you're programming things the way you're programming things, or why you're not letting them progress, or why you're asking them to take it easy. It's easy to just say to them, like, listen to me, but really like taking that time to say, this is why we're doing this. This is why we're not doing this. This is why I want you to do cycling instead of running, or this is why I want you to be able to jump before you can do this, or whatever it is within those treatments and rehab. Getting really good at talking to patients and educating them on their pain as well is another massive one that I think really helps. They were the things that I really took away from both of these experiences, and even just clinic weekly throughout 5th year, it's been a massive improvement of mine to how I'm educating or explaining things throughout a treatment. And you can really see how that impacts the patients and empowers them to be able to manage their own well-being and treatment a lot better. So that is about it. So this covers off domains 2 and 4, so patient management being 4, and examination, diagnosis and treatment planning for domain 2. I hope you've enjoyed it. There'll be separate recordings going through the rehab program on PhysiTrack and the 2 protocols for the Achilles as well. Thanks. So goals in rehab. So this is sort of how the rehab plan ended up panning out in 4th year. So they're probably not necessarily goals, they're more just things that sort of happened as a result of how we were going through rehab. So getting the ankle range of motion back, restoring normal gait, so still not able to walk quite right. So there was a bit of a foot slap on that left-hand side, and he was very fear avoidant, so not just taking short steps on that left side and not putting his full weight through. Then we wanted to start loading the tendons, so isometrics, concentrics, eccentrics. Then we went into some light plyometrics and return to sport. So, like I said, that's sort of just what ended up happening. In hindsight, I probably would have wanted to change that a little bit and have those set out from the start, so that we knew exactly where we were going and what benchmarks we had to meet before we moved from goal to goal. 5th year, phase 1 was restoring our full range of motion. Like I said, tendon rehab protocol, sort of pretty standard, isometrics, concentrics. But then I went into, we actually had a setback after concentrics. So pain levels had gone up. There was, I think, a re-injury at footy, not a sublux or anything, just a bit of a knock that did set that back, and our pain levels were up. So we sort of backtracked to those isometrics. And then once that was back under control, we went into like a general strength phase. And that was sort of always the plan from the start, just so that it was generally more stable in that area and she was better able to manage work and football. So that's sort of how I approached fifth year, which ended up working quite well.